session. And we want to welcome all our experts that have joined us this afternoon. And
this meeting is being recorded
by Dr. Lungu, Dr. Muyoyeta, and Dr. Zimba, Kevin. These will be our experts for this afternoon as we deliberate. We also have a case that is coming in from Sichili Mission Hospital, Mulawezi in Western Province, an interesting case. And so we'll be hearing from Stanley Kazima, who will be presenting. And I hope they've managed to join us this afternoon. So without further ado, I'm going to invite Madam Eta to give us a recap of what we had discussed last week. Madam Eta.
Thank you very much, Dr. Ziambo. Good afternoon, everyone. So last week, we learned about COVID-19 vaccination in people living with HIV. This was presented by Professor Lloyd Ling. And then in the introduction, it was mentioned that a Zambian study found no link between HIV status and COVID-19 severity, but he said the risk increases for those people with the severe HIV infection. So the COVID-19 vaccines authorized in Zambia significantly reduce the risk of one having a severe disease and death. But they also believe that they are safe for everyone. They're authorized, and studies have been conducted which have proven that they are safe for everyone to take, including people who are living with the HIV. So all people living with HIV are eligible for a COVID-19 vaccine, except the following. So those with acute and symptomatic illnesses, those who are commenced on RT, those who are commenced on ATT, and then like in the past 14 days. Then even those who refuse vaccine counseling, they can be exempted from getting the vaccine. We also learned that those recipients of care who have been initiated on PrEP or PEP in the last 14 days can be exempted from getting this vaccine. So the professor also outlined some achievements, some challenges being faced in the campaign of these vaccinations for COVID-19. So one of the achievements is that there's a substantial number of ART facilities which are providing COVID-19 vaccinations across the country. That's a plus. One of the challenges that he mentioned was poor documentation to capture people who are already vaccinated, which has to be worked on. So the other challenge was high refusal of people getting these COVID-19 vaccinations due to myths. And also there was another challenge of having inadequate space in ART clinics to incorporate these vaccinations across the country. So the proposed actions to these challenges were: one, to strengthen documentation for COVID-19 vaccination in ART centers, to print and utilize IEC materials that have been developed, and also regular monitoring of these ART clinics in terms of the implementation of the COVID-19 vaccination. So we also learned about the approaches on how to increase the vaccine coverage in people living with HIV. So we learned that one, in ART centers, that is, the first one is a careful planning on how to introduce this vaccination in those settings. The second one was to organize a COVID-19 vaccination session in those same centers. The third one was to arrange a COVID-19 vaccination site. The fourth one was the ART site vaccination setup tips, then to leverage on the ART services for COVID-19 vaccinations, as well as preparing for the session, storage, and vaccine transportation, and also putting into consideration IPC measures. That was just a quick recap. Over to you, Dr. Ziambo.
Thank you very much. Great reminders there on what we discussed last week. So this afternoon, allow me to bring to you Dr. Nyimbili, who just introduced himself and get into this afternoon presentation. Dr. Nyimbili.
Thank you very much, and good afternoon, ladies and gentlemen. I am Sulani Nyimbili. I am an epidemiologist working with CIDES, and I'm glad really to be a part of this team and to be able to share this topic titled BI-Directional Screening of COVID-19 and TB. The learning objectives for our session this afternoon is to describe bidirectional screening of TB and COVID-19 and highlight similarities and differences between these two diseases. We are going to outline the key steps for bidirectional screening and briefly discuss the overview of management of TB and COVID-19, mainly from the programmatic point of view. Yeah, so just as a reminder to everyone, I'm aware that this information is familiar to all of you, but just as a reminder, COVID-19 is a coronavirus disease, 2019. It's a respiratory disease that is caused by a beta coronavirus named SARS-CoV-2. And tuberculosis is equally a respiratory disease that's caused by a bacterium. I can say it's an ancient bacterium discovered by Robert Koch in 1882, but evidence of this bacteria is documented for over 1,000 years. So what is bidirectional screening of TB and COVID-19? So this is simply screening for TB in individuals who have suspected or confirmed a COVID-19, and similarly, a COVID-19 testing in individuals who are presumed or confirmed to have TB. So I'm going to pause here and hand over to Dr. Ziambo for our poll question number 1.
Thank you so much, Dr. Nyimbili. So dear network, thank you for joining us. We want you to participate in this afternoon's echo session by getting involved in some of these poll questions. So this particular poll questions here is wants to find out whether this statement is true or false. TB and COVID are major infectious diseases of public health significance. Both diseases are among the 10 causes of death from a single infectious agent worldwide. Is this a true statement or false? We have about 227 connections, and we're hoping that we can actually participate and get involved in picking which one here is a correct answer. So is this statement true or false? Okay. So far, so good. I see most people think the statement is true. Okay. All right, allow me to end the poll. So just to show you, this is how people have voted. Most people think that this is a very true statement. Okay, thank you so much for participating. I'll hand over back to Dr. Nyimbili to pick it up.
Thank you, Dr. Ziambo, and thank you everyone for the responses. So just to remind us, why should we screen for TB and COVID-19? Why should we screen for TB and COVID-19? Like you all saw from the poll question, TB and COVID-19 are major infectious diseases. They are actually amongst the top 10 causes of death from a single infectious germ, like worldwide. Just to share some statistics, about 10 million people fall ill from TB every single year. And from these, about between 1.4 and 1.5 million die. So if we do the calculations, this translates to about 4,100 every single day. And with the COVID-19, since the commencement of the pandemic, as of this morning, we had about 400 million people infected and about 5.7 deaths. So we can see the global impact of these devastating diseases. So what we're saying is that if we enhance screening, it will mean that we're going to detect these diseases early and subsequently reduce death and severe disease. And ultimately, we're going to be saving lives. You might be aware that as WHO, there is a global strategy to end TB by 2030. And screening and early detection is key, because eventually, when we are picking out these cases from the communities, we will subsequently decrease transmission of the disease to others. Okay.
So we will do another poll question, a second one. And this one here, we want to find out which one of these is correct. And so which of the following features can be seen in both TB and COVID-19 diseases? Which one of these features can be seen in both TB and COVID-19 diseases? A, the risk groups usually both involve old persons, people living with diabetes and chronic lung diseases. Then B, they have similar radiological features. C, the causative agent is similar. D, none of the above. So which one here of the following features can be seen in both TB and COVID-19 diseases? The risk groups are similar in pattern. It's old persons, people living with HIV, diabetes, and chronic are most affected. And similar radiological features, causative agents are similar, or none of the above answers are correct. Okay, so we have 260 connections, and we are inviting you to participate and pick which one will be a correct answer of this. Okay, we have got a few more seconds. I'll allow a few more seconds for us to, at least more than 55% of people have voted. Okay, I'll end the poll. So far, we have most people think A is correct, and others think it's D. So we're yet to learn. We'll see which one of these is actually correct. So we'll move on. I'll hand back over to Dr. Billy.
Thank you, Dr. Kozia. To answer our question, I'm going to share a comparison between TB and COVID-19. So this is just a summary. For starters, the pathogen in tuberculosis is a bacteria called Mycobacterium tuberculosis complex. Whereas for COVID-19, the pathogen is a virus, SARS-CoV-2. In terms of transmission, TB is airborne through respiratory droplets that are approximately below 5 microns. Whereas for COVID-19, the microns are larger, they're above 5 microns. So that's why it's called droplet transmission. In terms of infectiousness, TB ranges from between 1 and 4 people infected from one TB case and about 2 for COVID-19. So this means that TB is more infectious, it being an airborne disease. Diagnosis for TB is usually through sputum tests, and if we are using other samples such as urine or stool, we use other methods. For COVID-19, it's typically nasal or oropharyngeal swabs, and sputum can also be used for the diagnosis of COVID-19. In terms of the presentation of symptoms, fever is typically, tuberculosis is typically fever, cough of any duration, especially for PL-HIV, weight loss that cannot be explained, and characteristically drenching night sweats and chest pains. With COVID-19, the symptoms have really been evolving over time, depending on the organ affected, but predominantly difficulty in breathing, cold, fever, and sore throat. In terms of radiological features, I think this is important to highlight, is where TB is usually apical, especially in HIV-negative individuals with effusion and also evidence of lymphoadenopathy as well as cavitation. And we don't usually see these lesions with COVID-19. Prevention of both diseases is through good respiratory hygiene. And for TB, since it's a curable disease, you can actually prevent that transition from latent infection to active disease through TB preventive therapy, either using 3-HP or isoniazid. You can also prevent TB through vaccination. I'm sure most of us have received this vaccine. For COVID-19, it's generally good respiratory and hand hygiene and physical distancing so that we cannot infect others if we're within a range of about 2 meters. Remember, I mentioned that the droplets are slightly larger, so they easily fall to the ground and can even infect the environment. So social distancing and just general good hygiene practices is a good way to prevent COVID-19. And we are glad that we have got a wide range of vaccines that are available now to prevent infection, and if you get infected, to really reduce severe disease and death. Treatment for TB is available and it's free. It's a combination of drugs, of antibiotics. Whereas for COVID-19 being a virus, most of the treatment is supportive in nature. So this figure is reminding us of the symptoms that I mentioned. We can see that for COVID-19, the fever tends to be high grade above 39 degrees Celsius, whereas for TB, it's usually low grade. And one thing which is notable is that COVID-19 is generally an acute disease with rapid progression from as short as a few hours up to over a week, then symptoms develop, whereas TB takes a bit of time, ranging from weeks and sometimes to months and years. But what is characteristics are the similarities in terms of shortness of breath and chest pains. There is cough in both diseases, though for COVID-19, it tends to be dry, and for TB, it's productive. Just to highlight the salient similarities, we mentioned the risk groups. Older persons tend to be at risk, as well as HIV positive individuals with diabetes and chronic lung disease. The clinical features, both diseases target the lungs primarily, and as a result cause respiratory illness. We did appreciate the modes of transmission. It's via respiratory droplets, although the size of these particles varies. And you may agree with me that that the congregate settings really predispose transmission of both TB and COVID-19. And in both diseases, there is almost always a non-contact with active disease. In terms of the differences, we mentioned the rapid progression in COVID-19 and the high-grade fever. Just to mention that with new variants, the presentation of characteristic symptoms of COVID-19 has been changing or evolving over time. For instance, Omicron did not really present with sore throat and fevers. With TB, these are usually the symptoms, though depending on the organ affected, we may see non-typical symptoms or signs of TB. So some key considerations which we need to remember is that we need to think about COVID-19, especially in individuals who are newly diagnosed with TB, including those who are on treatment, but then they develop, or rather their symptoms deteriorates. So the presence or history of TB increases the risk of SARS-CoV-2 infection because of the damage to the lungs. So this TB co-infection actually also increases the risk of severe disease and even death due to COVID-19. So this association with rapid and severe symptoms and disease progression is likely to lead to poor outcomes for both diseases. I would like now to draw your attention to what we call post-acute COVID-19. I'm sure for those of you who have been infected and developed symptoms, you may have not fully recovered and were experiencing some symptoms that lasted from several weeks and even up to months. Most people, though, do not experience a symptom. So this condition called post-COVID-19, it occurs in individuals who have a history of probable or confirmed SARS-CoV-2 infection. Like I mentioned, it's usually 3 months from the onset of symptoms. So the common symptoms you may experience may include fatigue, shortness of breath, cognitive dysfunction. Some have also mentioned loss of memory. So there are a series of symptoms that people have experienced, but these are the most common ones. So these symptoms may be new from onset, and they may persist for a couple of months. So this is just showing us an overview of this post-acute COVID condition or PAC. We did mention that the acute presentation can be up to 3 weeks. Then from 4 to 12 weeks, we call it long COVID. And if the symptoms persist beyond 12 weeks, we define it as post-COVID-19. Yeah, just to underscore that post-acute COVID-19 is an emerging health condition in the country. And there have been a constellation of symptoms that have been reported. Now, given the scope of the pandemic, and it's evident that COVID-19 is here to stay, we really need to ensure that we implement bi-directional screening for TB and the COVID-19. This is really a necessary step, and the Ministry of Health embarked on an initiative to build the capacity of selected health facilities throughout the country through a series of training and capacity building, so that we can better manage post-acute COVID-19. So these facilities are characteristically called PAC clinics. So in some other documents, you may find this terminology. It's simply referring to post-acute condition clinics. So these are facilities that have been activated to provide this service to the community. So I will run you through some steps for bi-directional screening of COVID-19 and TB.
Okay, so before we do that, perhaps we could just get to engage our network with another poll. So this particular poll here, we want to find out what you know about bi-directional screening. Bi-directional screening for TB and COVID includes symptom screening, that is cough, symptoms, and suggestive of TB. Testing for TB, COVID-19 testing in newly diagnosed patients attending to the TB clinic, or those that have the worsening symptoms of respiratory symptoms. So which one here is correct? Bi-directional screening for TB and COVID-19 includes symptom screen, A. B, testing for TB. C, COVID testing in newly diagnosed patients attending TB clinic, or patients on treatment with new or worsening respiratory symptoms. Or D, all of the above. Which one is correct? Okay, so we have got 300 connections. And so far, we're looking forward to the network participating and polling which one is the correct. So we have 10 seconds left. Okay, let me end the poll now. Share the results. So that's an interesting finding. About 50%, 56% think it's D, 33% think it's C. Okay, let's learn some more from Dr. Nyimbili.
Thank you. So bidirectional screening for TB and the COVID-19 basically involves a two-pronged approach. The first is investigating the patients that are presenting to the PAC clinic for TB screening. So it may not necessarily be a PAC clinic per se. It can also be a point wherever COVID-19 testing is being done. So for you to screen for TB in this scenario, you start with symptom screening. So you screen the client based on the symptoms, the characteristic symptoms for TB, cough, and other symptoms that are suggestive of TB. Then if the facility has a lab or where you can refer samples, these samples have to be tested either using a gene expert, microscopy, or culture. It is always encouraged that if you have a chest X-ray, you include this in your screening. For COVID-19, this involves really testing for COVID in individuals that are attending TB clinic. Again, this may not necessarily be restricted to the TB clinic, but all the points within the facility where screening for TB is being done. So this will also include your presumptive TB clients, and typically you're newly diagnosed, as well as individuals who have been on treatment, but their respiratory symptoms have begun to deteriorate. So you test these individuals for the COVID-19, either a rapid antigen test, where you can receive the results within a few minutes, or a PCR test, which is the gold standard, which takes a bit of time. And if you have got an integrated testing platform on the expert machine, you can also use it. So this is just showing the key stages which we need to factor in, the symptom screening, and whenever a client is presented, you need to stratify the risk in these individuals based on the HIV status. What is important in both scenarios, both TB and COVID-19, is an exhaustive history taken. This is important because you'll be able to identify an epidemiological link of these individuals. Of course, you follow this by the physical examination, and always encouraged to include a chest X-ray. So these are the things I mentioned for TB, sputum microscopy or expert, and then you can get an nasopharyngeal or an oral swab for COVID-19. And if the diagnosis is positive for TB, you notify the case, first of all, and then initiate on treatment. And then for COVID-19, you can consult the treatment center and ensure that you notify the particular case. So this is showing us the algorithm for TB screening in a PAC setting and all the settings where we are like testing for COVID. Like I mentioned, a client presents with more than 3 weeks of acute COVID-19, check for the symptoms that are consistent with TB, and then test for TB using the methods that we mentioned. Of course, through all these procedures, you need to ensure that you adhere to the basic principles of IPC. And if a positive, notify the patient. And if it's an individual that you're suspecting to have acute COVID-19, you make all those considerations for co-infection, as well as for presence of other symptoms that are suggestive of TB, like night sweats and unexplained weight loss. Just to mention that to conduct such a screening comprehensively, we really need to ensure that we have got adequate human resource and equipment in place. We need to ensure that the clinical assessment tools are available and understood by all the healthcare workers, and ensure that you have lab capacity to conduct these tests. If this capacity is not available, we need to make arrangements to courier samples. So this is just showing us the algorithm for COVID screening in a TB clinic setup. It's similar where you have got a presumptive TB case on my left and an established TB patient on my right. So similarly, you run the algorithm, do the testing, and if positive, notify. And if negative, move further to investigate other respiratory infections. So in terms of the overview management of TB and COVID-19, following diagnosis of both diseases, we need to follow the established guidelines for the management of TB and COVID-19. So this is from the programmatic perspective, and really the focus in a pandemic period like now is to sustain essential services for people that have been affected with TB during the pandemic. I'm sure our panel of experts will be able to infer on the clinical characteristics, or rather the clinical management of TB and COVID co-infection. Just some key considerations is to ensure really that for our TB patients, we ensure that we provide adequate TB drugs that are aligned to the scheduled clinical visits. So the diagram is just showing us a proposal we adapted from the consolidated guidelines, which is basically depicting how you can align and plan the pickup of drugs for these individuals that really they're aligned to their visits. So you can align this based on the wave of the COVID-19 surge. Gladly now, our numbers are reducing, so things are really returning to normal. But in the case of surges, you have to make these adjustments to the plan. Other considerations is really to provide the continued patient support through our community health structures, and if these are absent, we need to use technology and see how you can follow up and counsel some of these patients via phone. Contact tracing is very, very key. Always ensure that this is done, but adhering to the standard procedures for IPC. In the case where TB has not been diagnosed, these individuals can still be placed on TPT. There has not been any contraindication for this, and you could actually schedule this in such a way that for people living with HIV, this aligns with the ART pickup. Last but not least is always to ensure that we adhere to the infection prevention recommendations through triaging of the clients within the facilities, ensuring that there's adequate ventilation and that there's provision of adequate PPE for both the patients as they come to the facilities, as well as the healthcare workers. In summary, really, to underscore is that for every individual who presents to the facility with either COVID or TB, we have to ensure that we screen for both diseases, because the risk really is increased with this co-infection. And similarities in presentation, it's very easy to miss the diagnosis of both diseases. And using the existing structures and resources, we do have an opportunity to really leverage these and integrate TB and COVID screening in our testing. The efforts are still being made by the ministry to really build the capacity of healthcare facilities to manage the pack conditions. And with time, so that every healthcare worker can be able to really test for both TB and COVID-19.
Thank you so much. Very, very important information coming through there, Dr. Nyimbili. We appreciate. Right now, as we move on to the questions and the comments from the audience, maybe we just quickly do, we report the questions. Quickly, network, maybe you could respond to these ones now after all the information has been given. What do we think about this statement here? I'll only give about 30 seconds for this one, and then I can end the poll. Okay. Okay, so I'll end the poll now. So Dr. Nyimbili, most people think it's a true statement. Would you like to make a comment on that, on this particular poll?
Well, I think the statistics, the global statistics have actually shown, and to some extent, COVID-19 has actually surpassed TB in terms of the number of infections.
Okay. Next poll question. So this one, dear network, which of the following features can be seen in both TB and COVID diseases? So you have got A, they will both affect mostly persons living with older persons, people living with HIV, diabetics, and chronic lung diseases. Similar radiological features, similar causative organisms. None of the above. So which statement here is correct? We'll give you another 40 seconds or so to pick which one is a good, correct answer. Okay, I'll end the poll just now. Okay, so we have got people think A is correct. Some think B, some think it's D. Would you like to make a comment on this one, Dr. Nyimbili?
Well, yeah, the correct answer is A. If you remember, I did highlight some of the radiological features that are different, and it's easy actually to confuse the two in terms of the chest X-ray presentation. But the correct answer here is A, where we are seeing the aged as well as individuals with comorbidities are most at risk. That's why these were prioritized for vaccination when we didn't have enough vaccine for the general population.
Thank you so much. The final poll question. Okay. About directional screening for COVID includes symptom screening, testing for TB, COVID-19 testing. All of the above? Which one here is correct? Ended. Looks like somebody closed the poll. Sorry about that. So we want people to poll. Just a few more seconds. Okay, I'll end the poll. So Dr. Nyimbili, we have most people think that D is the correct answer here.
Yes, it is the correct answer. It's all of the above. Remember, it's bi-directional. It's screening for both TB and COVID-19. I think A and B are speaking to TB screening, and C is speaking to COVID-19.
Okay. And so these were the references to this particular presentation. So thank you very much, Dr. Nyimbili. That was very, very important information shared with the network. And I hope we managed to pick up one or two things from there. So before I ask Sichili to make their presentation, I hope we're ready. Team from Western Province, are we good to go?
Yes, sir, we are good to go. We are ready.
Okay, thank you. Thank you very much for being available and to present. We appreciate your support. I can see we have got Kawa School of Nursing, then the HNPs. Thank you for joining us. We're expecting you to contribute as we discuss this case this afternoon. So Sichili, are you able to go ahead and make a presentation? Just share your slides, then we can move on to that. Then afterwards, then we can probably discuss some questions, and then we'll invite also our experts to come on board and just make some comments on what has been presented so far. I know Dr. Lungu is on the call, the currently Assistant Director of Public Health and Infectious Communicable Diseases. And then we also have Dr. Kevin Zimba, who's on the call as one of the experts. Western Province, are you ready to go?
Yes, sir. Hello, Dr. Ziambo. This is Dr. Lushenga, the medical mentor for Sesheke and Mlowezi. I will take the network through the case.
Thank you so much for joining us, Dr. Charles. Please go ahead and put your slides in the presentation mode.
Okay. So our clinical mentor was ready to prepare, but something came up and is not able to present. So I'll present. But the team from Chile is here with us also for the question and answer session.
Thank you so much.
All right. Okay, so I'm just sharing the slides now. Okay, so this is the case. Dr. Ziambo, confirm you can see it. Dr. Msesha, kindly just put it in slideshow.
Yes, we can see it. Excellent, thanks.
Okay. Okay, may I have the next slide, Dr. Msesha? You can see the next slide. Okay, so this is the case. We are presenting the case of a gentleman, 56 years old of age, initials of the name TM. that presented with a 3-week history of a productive cough, night sweats, chest pains. He had lost appetite and also had lost weight. He also complained of shortness of breath. So his past medical history was essentially non-revealing, as his HIV status was unknown though, but there was no history of either hypertension or diabetes, any other significant medical condition.
Dr. Charles, we can't hear you. Are you speaking? Looks like we have lost Dr. Charles. I think the network seems to have dropped. Okay. Do we have anybody on the Western Province with a team? Okay, I think let me just share the slides. We'll read it from here so that we can discuss it. So dear network, are you able to, I hope you can see the slides for the case. So as the team was sharing that this was a 56-year-old who had cough, night sweats, chest pains, loss of appetite, loss of weight, and shortness of breath. This had been for 3 weeks. HIV status unknown, had comorbidities, diabetes, and hypertension, and had not yet been vaccinated for COVID, was divorced, and was taking alcohol as well, and he wasn't doing anything, being kept by the brother. And then on examination, these were the vitals. The BP was normal. The vitals, in terms of the temperature, was quite high. Respiratory rate was high.
Dr. Ziambo, sincere apologies. I lost the connection.
Okay, no, it's okay. It's fine. You can pick it up, Dr. Charles.
We are able to see the slide.
Can you see the slides?
I put them on slide.
Okay, let me just redo that.
Thank you.
Is that better? Dr. Charles, you can see that?
I think it's better.
All right. Please go ahead and you can pick it up from the examination findings. Can you hear us?
Be not so stable, but yes, Dr. Ziamba, I can hear you. Can you hear me? Hello?
Yes, yes, we can.
Okay, great. So physical examination findings, according to the examination we did on the 24th of January, reviewed the following. His blood pressure was 116 systolic and 78 diastolic. His pulse was at 101. His temperature was elevated at 39.3 degrees Celsius. Respiratory rate was 26 beats per minute, and his weight was only 39.3 kgs. Middle-aged man who was neither pale, jaundice nor cyanosis. Of his chest, we had crepitations, especially on the left side. He was also noted to be dyspneic, and he was visibly wasted. His CVS examination was essentially normal, although it showed a tachycardia. Other systems had no significant.
We seem to have lost Dr. Charles again. Okay, so, and they made an impression of COVID-19 with TB and hepatitis B. And so these are the investigations done. So hepatitis surface antigen was positive. They couldn't do a CD4 count. It was positive for COVID. And also the HIV test was not done. And then the liver enzymes were slightly elevated. The urea was okay. The creatinine appears to be okay. And so the particular questions for this particular case is, what could be the best treatment option for this client who has been diagnosed with both TB and COVID-19? And then how best can we manage this client at a facility and community level? Very, very important questions here. And so as we discuss this, before I call on the experts, I'm just going to invite the network to make some comments on what they think would be the best way to manage this particular patient here, who we have here. So we invite for any questions, any responses from the network. So we have some questions here. What could be the best treatment option for this client who has been diagnosed with both TB and COVID-19? How best can we manage this client at facility and community level? So we are inviting the network to make some comments. I've seen a hand by Mbozu Mutondo. Mbozu Mutondo, please go ahead and unmute yourself and make your comment. Then afterwards, we'll have Kasanka. We'll have Kasanka Rural Health Center make a comment. Mbozu?
Hi, good afternoon, team. I'm sorry, because of the bad network, I was unable to ascertain the TB and COVID. They were laboratory confirmed.
Yes, both. I think they didn't clarify on the TB whether it was laboratory confirmed, but the COVID, yes, it was positive for COVID. Unfortunately, the team is struggling with network, so they couldn't give us a clarification on that one. Yeah. A comment from Kasanka Rural Health Center.
Good afternoon.
Afternoon.
Yes, looking at our patient, I think how best we can help this patient is we focus on first, we stabilize the patient on TB treatment. As of COVID, we can treat based on the symptoms present. For example, if the patient will need the oxygen therapy, we can commence oxygen therapy. I think that's how best we can manage this patient with the TB and COVID-19. I submit.
Thank you very much for that important comment, Kasanka Health Center. Yes, Mbozu, you're back.
Yes, sorry, I had a bit of challenge with network. Also, just because it was noted earlier on that we were not sure of this client's RVD status. So maybe it might also help to test them for HIV, because now we're wondering how this person is able to get two opportunistic infections at the same time. And then not only that, we might also want to make sure that this person is isolated so that they don't infect other clients or other people.
Thank you very much. IPC measures to be taken into consideration, confirm the HIV status as well. Thank you very much for those comments. Do we have any other additional comments from the network? We can look at both questions here. How do we manage this particular patient in terms of at a community level? I've seen a comment here from Matthews, says that the client should be initiated on antituberculous treatment immediately, and then take care of the COVID as per symptoms presentation. Then Sipeso also says that the diagnosis of TB was via chest X-ray. So it would have been interesting to see how the chest radiological features were on this particular patient. I know that the symptoms seems to have been directed as TB, and the chest X-ray would have been very, very happy to see how the chest X-ray was looking because of some of those findings may be characteristic. Okay, thank you very much, Sipeso. Any other comments? There's a question here, was hepatitis B confirmed in the lab? I think they confirmed that they did a hepatitis B surface antigen, and it seems to have been positive. Okay, network, are we, any other? Okay, I'm seeing here, Grace, you are saying that contact investigations for both TB and COVID needs to be done at community level. That's very, very crucial. Okay, so these were the tests that were done initially. So here is a question that, so I can see some comments, I just run through them. I select the patient first and further investigation later, so that we investigate this patient, and then any reason for not doing CD4 counts. And I think we wouldn't want to go to a CD4 count before we confirm the HIV test here. And they're asking, why did we do HIV tests? I think the team is not here to make a comment on that one. I don't know whether they just didn't document it or not. So, but anyway, so at this time, I'll invite some comments from our experts on the call. I'll invite Dr. Lungu to make some comments on this. Okay, so we have got a result that the HIV test was actually negative. Thank you so much, Sichidi Mission, for making that clarification. So Dr. Lungu, would you like to make some comments on what has been presented so far and what can be done for this particular patient here? Dr. Lungu? Not sure if you're talking, we can't hear you. Dr. Zimba, would you like to pick it up?
Yes, Dr. Jam.
Good afternoon, Dr. Zimba.
Hello. Afternoon. Dr. Nyimbili, nice presentation. Thank you, and the team for the case, a very nice case. You want me to pick up the case or the presentation itself?
You can speak on both, Doc.
On both. No, no, I really like the case, and I think on my end, I would like just to emphasize on the need for us not to be afraid of the COVID-19 patients, because I think when COVID just started, when somebody makes a diagnosis of COVID, people would run away and not want to investigate other conditions around the patient. So it's good that over time we've learned to live with COVID and work with it. And I've seen the bi-directional referral of COVID-19 and TB, that patients who come in with COVID-19, it may just be a chance for us to investigate them for TB. And those patients who come in with TB, it may be a chance to investigate them for COVID-19. Not only is it TB, but let us see all patients who have a cough or a respiratory tract infection. Let them be investigated for TB. Remember that our presumptive diagnoses are made from patients who come in from with respiratory symptoms. So all patients whom we are seeing in facilities who have respiratory symptoms, let them be in our presumptive registers. We investigate them for presumptive TB, collect as much specimen as we can as possible, and try and investigate a diagnosis of TB. And those whom we make a diagnosis of TB, we do contact tracing for the children, especially because a lot of children out there are being infected with TB by the adults who are coughing out the TB. I think that's what I would speak on the presentation. Over to you, Dr. Jam.
Thank you very much. Any comments on this particular case that we have here? So there's a question here saying, what was the clinical reason for suspecting hepatitis? And what about the gene expert results? Sichiri, I know you're struggling with network, so perhaps you can just respond in the chat so that we can clarify on the actual presentations of this particular case. Any other comments from the network?
Okay, so for example, so we have a question. I think our first question that we're being asked, although I don't know, I can't respond to Dr. Mbiana's question asking on why we thought of hepatitis. But if we go to your first question, what would be the best treatment options for a client who has been diagnosed with both TB and COVID-19? So I think what we get from the presentation Dr. Nyimbili gave is that we see that COVID is a curable disease that has a treatment for TB. Sorry, TB has a definite case of TB. We should put this patient on our TB treatment. And then we need to now start thinking of the COVID-19 management is basically supportive, as we know. There's nothing like give us information based on the clinical status of the patient that is there, whether they will need or other kinds of treatment that are there. So we need to start the TB treatment and do the supportive management for TB. That would be my suggestion on this question, the first question. Okay.
Thank you.
When it comes to the second question, I don't know what
It's struggling to hear you, Dr. Zimba. The network.
See today for on community level. So at facility level, first of all, is that we need to take preparation of our COVID. Can you hear me now? Can you hear me?
The network is a bit difficult. We're struggling to hear you.
Let me try and use the Wi-Fi. Is that better?
Yeah, that's better. We can hear you.
Dr. Ziambo, is that any better?
Yes, that's better, Dr. Zipper.
All right, okay. So we are saying at facility level, so we need to make sure we take care of our infection prevention measures. As we know, I think Dr. Nyimbili did highlight in his presentation how easily to get COVID-19 transmitted and TB transmitted into infection. So in the acute phase, we don't want our staff getting sick from COVID-19. We also don't want our staff presenting with TB several months after being exposed to this TB patient. So infection prevention measures have to be taken when we're managing this client. Then at community level, we need to make sure we do the contact tracing, like I said earlier on. Very important for both COVID-19 and TB, they need to have contact tracing done, because when you do contact tracing, you mitigate the spread of COVID-19 to other people. So this client was in contact with so many people. You make sure that those people the client was in contact with, start the isolation measures to prevent infecting other people. In terms of the TB, we need to screen the family members of this patient, the people he's been in contact with. You will note that it's surprising that when somebody is diagnosed with TB, all of a sudden they live alone. They have no other people that they live with, which is not true. So for every TB case that we diagnose, we should have at least 6 contacts being elicited. That's a good elicitation ratio. And it will help us pick more TB cases that we can, and even the COVID-19 cases, and halt the spread of both COVID-19 and TB. Over to you, Dr. Zim.
Very well put, Dr. Zimba. We really appreciate your comments and stepping in. I like the way you've put it together in terms of facility management of this patient. I think it's there's concern for the patient, and then there's also concern for the carer. So meaning we maintain our IPC measures, and then also we go ahead and treat the patient. So, and then at community level, we will make sure that we do our contact tracing, family, household level, and they continue IPC measures as well. Thank you very much, Dr. Zimba, for those comments. There's been some clarifications here. Looks like the confirmatory hepatitis B was negative, the GeneXpert was negative, and what prompted the hepatitis screen was the splenomegaly that the patient had. And then, and the HIV test also was negative. So, those are some of the responses from the Sichidi team. So I think with those very fine comments from Dr. Zimba, I don't know if we have got any more comments from the network on this particular case that we have had. If there are no further comments, I just want to find out from Sichidi Mission if so far what has been given as responses to your questions, you are okay with it, and if there are any clarifications you want to make about it. So looks like Sichidi, you didn't really give us, I think, some information that were documented here were not quite a bit misleading. So that's the comment from one of the people that are here. So I know Sichidi is struggling with network, so we will take it that if you have any comments, you put it in the chat. So I think this has been a great presentation, and we appreciate your participation, dear network. And so before we just close this out, I'll invite Dr. Nyimbili just to give his final comments on what we're discussing today.
Thank you very much, Dr. Ziambo, and thank you everyone for the participation. Really just to really underscore that it is within our capacity to ensure that we implement bi-directional screening. I always remember being told that the most sensitive screening tool in the health system is actually the healthcare worker. Even before we think of the chest x-rays, of the gene experts, and of the tests, the first instrument is us as healthcare workers. We need to really are really going to expedite our efforts to halt transmission of TB and reduce transmission of COVID-19. Guys, thank you so much. I've learned a lot from all your presentations and looking forward to the next sessions. Thank you.
Thank you very much, Dr. Nyimbili. I think that those final comments are very, very important and critical. Dr. Lungu, please, you may just give your final remarks on what we've been discussing today.
Yeah, thank you very much, Dr. Ziambo, and apologies for not taking up the call when you did call. Let me just start by appreciating Dr. Nyimbili, who has done a fantastic job covering such an important topic. In addition to what has been discussed on the platform, I want just to bring out the issue of TB preventive therapy in people who have COVID, especially those who are living with HIV. As you learned from this presentation that the dual infection is likely, and also the likelihood of a poor outcome is also very high. The other issue to bear in mind is that some of the COVID patients, we may use steroids. And if we are using steroids in people living with HIV, we are doubling up, or if not increasing the risk of activating latent TB to active TB disease. So therefore, it's imperative that we should ask about the history of TB preventive therapy as we do screen for symptoms or presence of active TB disease. For those individuals who've never taken TB preventive therapy, we should ensure by any means that we do commence them on TB preventive therapy unless there is any contraindication, so that we do prevent them from actually getting active TB disease. The other points just to emphasize, as the others spoke about, if a TB patient starts to deteriorate while on TB treatment, one of the things that we should always ensure is test them for COVID. And similarly, COVID patients or post-COVID individuals who start to deteriorate, you do test them for active TB disease. So indeed, just for the grassroots to appreciate that the two diseases can occur at the same time, and other conditions also can, in due course of TB treatment, one can contract COVID-19. Therefore, dual screening or bi-directional screening is very, very important. Thank you, Chair. Over.
Madam Nomsa.
I was wondering, there's some silence. Dr. Ziambo still on the call?
Yes, yes, Madam Nomsa, we are on.
I didn't hear your wrap up. Sorry.
We did wrap. We wrapped up very well.
Oh, okay. Okay. Then it was my network that dropped then.
Yeah.
All right.
So
had an internet challenges today.
Yeah, looks like a lot of people had internet challenges today. Yeah.
Yeah.
Dr. Ziambo.
Hi.
When you're wrapping up, we didn't hear you.
Oh, so lots of people predicted. Okay.
As well. Huh?
Oh,
we didn't hear you. Hmm?
Okay, it's maybe I also, the network also went away. Apologies, dear network. We thought we were heard, and we said,
okay.
I actually did announce that next week we'll have Dr. Wupem Sonda on adolescent HIV, and that we've come to the end, and I hope we'll see you next week. Yeah.
I think we missed that. I think we missed it.
Apologies for that.
Okay. All right, then. Bye.
Okay, then. Thank you very much. Bye.
Bye-bye.